Hi, William.
Hi, Gopal. How are you?
I'm fine. How are you?
Good. Good to meet you. Did I say your name correctly?
Uh, yeah, did I say your name correctly? William
Yeah.
Schpero, is it?
Um, so you can just call me Will
Okay.
and yeah, Shapiro.
Yeah. I call you Will
Sorry,
or
you're breaking up a
William.
little. You're breaking up a little bit. Can you hear me?
Okay. Just hello. Can you
I
hear
can hear
me
you
now?
now. Yeah, yeah.
Yeah. S- So let's start or hello.
I can hear you. Can you hear me?
Yeah,
It seems like there's
you
a bit
can
of
hear
a.
me, no?
I can hear you, but it seems like there's a delay maybe.
Okay. I think the network is unstable, I think. But I can hear you properly.
Okay. Well, I guess we can get started and try it and always, I guess, try something else if we need to. But you can hear me okay now?
Yeah, that's fine. Can you hear me now?
I can hear you. Yeah, I think you're okay.
Yeah. Okay. You are from New York, right?
Yes, I'm in New York. Yeah,
Yes. Okay.
yeah.
I'm from India.
Nice. Well, thanks so much for inviting me, and thanks for doing this series for IHEA. It's wonderful.
Yeah. So let's begin.
Sure, that sounds
If
good.
it's fine from your end. Today is the third series of the Early Career Research Group interview series. Today we have one of the special guests with us, Professor William Shapiro. Good morning, William.
Good morning. Thanks so much for having me.
Yeah. So, Mr. Professor William Schpero is a health economist and assistant professor in the Division of Health Policies and Economics of the Department of Population Health Science at the Joan and Sanford I. Well, Medical College of Cornell University. He is also an associate director of the Cornell Health Policy Center and Cornell Center for Health Equity. Professor Williams studied Medicaid and healthcare safety net in the United States. Through his research, aimed to identify policy levers to address racial, ethics, and socio-economic disparities in health and healthcare. He is also the co-founder of the Medicaid Data Learning Network and Medicaid Insights Colloquium. His research has mainly appeared in a number of journals, research academic journals, including the New England Journal of Medicine, the Journal of American Medical Association, and Health Affairs. It has been featured in Bloomberg, CNBC, Politico, The Washington Post, and other news outlets. He has received his PhD in health policy and economics from Yale University, during which he has also pre-doctoral fellow in aging and health economics at the National Bureau of Economic Research. He is also a proud winner of the annual student prize from IEA. So that's a big introduction to you. So first of all, I'd like to ask you how all this began. How was your academic journey and how did you start your research in health economics?
Yeah, well, thanks so much again for having me. In many ways, it was a series of sort of lucky accidents. So, in undergrad, when I was in college, I had two main interests. One really was in domestic policy here in the US and in health policy specifically, but I had no really idea what it meant to do work or to do research designed to inform health policy. And so for a long time, was set on going to medical school, but knowing I really wanted to do work designed to inform health policy. And so an undergrad actually had a double major both in biology and government and political science. And so was very set down this medical school path. At the same time, I had another big interest at the time, which was journalism. So actually was very involved in the student newspaper at my college, and in retrospect, I think there are many parallels between journalism and research. Both involve testing a hypothesis, engaging in an investigation. In the applied policy world, a lot of research is around promoting accountability and transparency in public policy. And so many similar, I think, parallels. And as I neared the end of my time in an undergrad, I think at that point was sort of not as certain I wanted to pursue a career in medicine, but really wasn't sure what I wanted to do. And was debating, do I go to medical school, but end up working in policy? Do I go to law school? Was considering going into journalism. And I'll say I really had no conception of what it meant to get a PhD. I didn't know anyone with a PhD aside from my professors, and had no sense of what a career as a PhD trained social scientist looked like. And so again, as I finished up undergrad, really unsure of where I would go, and I sort of half-heartedly applied to a copy editing and research job at a major news magazine in the U.S. And perhaps as a sign that that was not the right career for me, I of course misspelled the name of the person who was doing the hiring on the cover letter. Anyway, I did not get that job. And I lucked into what was really a tremendous opportunity, which is when I was in college. So I went to Dartmouth College for undergrad, and the president at the time was someone named Jim Young Kim, who many folks listening may know. He went on to become the 12th president of the World Bank. At the time, he was, when I was in college, he was the president at Dartmouth. And this was after a really distinguished career in global health, where he was one of the co-founders of Partners in Health, and was really at the vanguard for thinking about trying to scale evidence-based interventions to improve longevity worldwide. And so I got to know him a bit when I was in college, and ended up staying on and working for him for a year as a sort of research assistant and speechwriter. And that experience was really transformative, where I think really learned a lot more about the sort of power of research to affect positive change in public policy. And during that time working for Jim Young Kim, I also began collaborating with another group at Dartmouth. And so it's something called the Dartmouth Institute for Health Policy and Clinical Practice. And it was a department, a center that had formed a few decades prior. And although I didn't know this when I was a college student, had become really one of the leading groups in the US studying health policy. And it had gotten quite famous for work begun by someone named Jack Wenberg, trying to understand regional variations in the US in healthcare spending and outcomes, and to what extent that variation was warranted, was indicative of sort of underlying need among patients, or was unwarranted and might be indicative of some level of waste. And that research ended up having considerable impact in shaping the evolution of US health policy, and ended up being incorporated into law under the Affordable Care Act passed during President Obama's term in office. And so anyway, I after working for Jim Young Kim, ended up going to TDI, the Dartmouth Institute, and I got a master's there, and then stayed there for a predoctoral fellowship. And that was my first time, really conducting research full time, where working under mentors like Carrie Kalla and Valerie Lewis at Dartmouth, began to get really interested in thinking about how we could design payment policies in the US to both theoretically improve spending and also quality outcomes. And I think I got really excited about the flexibility of the PhD, and that it could let you research and teach and write and interact with policymakers and have a direct impact on public policy. And so that sort of introduced for me what it meant to get to PhD, what it meant to be a PhD trained researcher, and solidified for me the idea of going on to graduate school. And so I ended up going from Dartmouth to Yale for my PhD, and ended up getting my PhD in Yale's interdisciplinary health policy program, where I specialized in the economics track. And it's a wonderful program. There are a number of them like them in the US, at least, where you get really good disciplinary training, and so in this case in economics, but get exposed to a sort of wide variety of interdisciplinary literature on health policy, recognizing that economics does not have all the answers we need to inform policy. There's lots of things we can learn from sociology, political science, management, et cetera. So anyway, had a great experience at Yale, getting my training in health economics, and then went on from there in 2019 to join the faculty here at Cornell. So I think, if there's one big takeaway, it's that I, by no means by the end of college knew what I wanted to do, or even again had a strong conception of what it would mean to pursue graduate training in economics, but what was able to solidify those interests through, I think, a series of really fortunate opportunities after college, and then was able to get the training I need to do what I hope wound up being really impactful research.
So while listening to it, your journey is like a boat going through different ports, different ways, like from journalism to economics to health policy. It's a very, very steam boat ride. So that's the beauty of economics, where we can relate to everything from health policies to politics to geography, everything amalgamated. So coming to your research interest of Medicaid and healthcare safety, can you tell us how you choose this particular field in health economics?
Yeah, I think my interest in health policy has always been in the context of understanding the causes and consequences of inequity. And I think work designed to understand, inequities and access and outcomes has an inherent, sort of normative importance to it that draws me to it. And so I've always been interested in my career in sort of thinking about identifying and testing policy levers to improve health equity. And that sort of drew me to the Medicaid program. So Medicaid is the US public health insurance program primarily for low-income individuals. And so it is inherently a disproportionate source of coverage for folks who are low income due to a variety of structural factors in the US. That means it also ends up being a disproportionate source of coverage for minoritized populations more broadly here. And so I think for those reasons, Medicaid is a really important policy lever for improving health equity. Again, some of it's because it's a disproportionate source of coverage for folks who have historically faced major structural barriers accessing the healthcare system in the US. Another reason why I think Medicaid is so important in terms of improving health equity is, although it is nominally a federal program, it is run independently by each of the states in the US. And so states have a lot of flexibility in terms of how they design the program, how folks experience health coverage in Medicaid. And that allows them to tailor the program to the needs of their populations, but it also can be a source of inequity. And we know that there are choices that certain states make that make it more difficult for certain populations in their state to get access to Medicaid, enroll in Medicaid, use Medicaid to access services, receive high quality services, et cetera. And so understanding sort of how those state level decisions affects variation in outcomes for low-income populations across the U.S. is major interest of mine. It also happens to be that introduces a lot of variation that, from a social science perspective, means that it's sort of much easier to or accessible to estimate causal effects. And so this variation underlies a lot of inequity, but also allows us to, I think, in some cases do a much better job trying to inform policy, using causal analyses. I think the other thing that's drawn me to studying Medicaid is just that it's understudied relative to its importance. So, Medicaid during the pandemic ended up covering 93 million people in the US. So it's, the single largest payer for healthcare services in the US by the number of people it covers. And historically, it's been pretty understudied relative to other programs. So the other big public program in the US is Medicare, which is primarily for older folks over 65. And again, one of the big reasons I think Medicaid historically has been understudied is because of this sort of federalist structure and the fact that every state has its own program that can make it challenging to engage in apples to apples comparisons across states, but also introduces major challenges in terms of the data infrastructure. So, Medicare, again, the program for folks over 65, is an entirely federal program. So we have one data set of so-called claims data where we can look at who uses what care for what services and who provided that care and what their outcomes were across the entire country. Historically, in Medicaid, those sorts of data either didn't exist or were hard to access, or there were lots of really meaningful data quality challenges. And that's begun to change in the last few years. So around the time I finished grad school in 2019, the federal government here in the US for the first time released a much more sort of higher quality federal data set that allows us to look at a very, very granular level at what's happening in the Medicaid program. And so I think that's gone a long way to sort of catalyze research on the Medicaid program. But it's sort of the lack of those data that in part attracts me to this program that we think has huge, huge importance, but where there are lots of sort of first order canonical questions that have not been asked in large part because of difficulty accessing data historically.
So for the listeners who are early career researchers, for them, this is a new uncharted area. So this is a new area, Medicaid, where they can write many research articles. So you are suggesting to them that they can look at this option for more research.
Yeah, so I think this is one big trade-off that folks often face in grad school or earlier in the career, which is oftentimes to begin work in a sort of newer, understudied area, there's lots of risks and there are lots of fixed costs, right? In terms of, getting access to data, building up data infrastructure, et cetera. But if you can manage those risks and overcome those hurdles, the payoffs can be tremendous in an area where, there's not been a lot of evidence to date. There historically has been lots of research on the Medicaid program, but much of that research relied on survey data or other data sets that did not allow you to estimate sort of heterogeneity and effects across lots of subgroups or look at lots of variation across states. And so it really wasn't until we had this new data set that came out in 2019 that we really could look at a very, very granular, detailed level at what's happening in the program. And I'll also say that, historically, most research on Medicaid is focused on sort of coverage and what happens when you expand access to coverage and what's the optimal design of coverage. There's been less research, again, because of these data limitations on the delivery system. So who are the healthcare providers who are participating in Medicaid? What are the incentives that they face? How do they respond to those incentives? How do we design a high quality delivery system in Medicaid that can improve equity in access to care and health outcomes? That's where I think these data limitations have really been a barrier and made it pretty difficult to do meaningful work historically. So, there are always risks in being really entrepreneurial as a grad student, for example, and going after new data. But there can be real return to that too in terms of being able to do really impactful work.
So my next question is, as you are a winner of the annual students prize from HIA. So can you suggest our listeners how to choose a good research topic for their research, and also how to place them for the HIA's annual students prize?
Yeah, I'll do my best. I obviously wasn't involved in the decision to grant that award, and so I don't know,
No,
what
not
the
the
big factors were for the committee. But I'm happy to give some thoughts.
mm,
What makes for a good research question? I think everyone has their own views, and um, I guess I'll offer a few thoughts. One is I remember in grad school, I took a public finance seminar with Amanda Kowalski, who is a fantastic health economist who's now on the faculty at the University of Michigan. And early on, she impressed upon us this idea of the research frontier. And the research frontier, in sort of her description of it, is that it's effectively a plot where on the x-axis you have sort of some measure of how important a question is. And on the y-axis, you have some measure of how well it can be answered. And oftentimes, with any given question, there are real trade-offs there, that the questions we can answer very, very, very well are often much more narrow and may not generalize very well. So we might be estimating a sort of very, very specific causal effect for a very specific population, but we can estimate that effect well. And then the big, big, big questions are often hard to answer well. They're hard to get at causally. And I think she impressed upon us the importance of being sure that at a minimum you're sort of pushing out on the frontier. So it's okay if it's really important, but maybe you're not answering it so well. Or maybe it's okay if you're answering it super, super, super well, but it's maybe not quite as important. As long as you're pushing out across, sort of both those dimensions as best as you can. You sort of don't want to be interior to the frontier. You want to be on the frontier on at least one of those dimensions. I will say, my own bias is that, if you're in the business of doing applied policy research, then being sure you're focusing on important questions is sort of the most critical bar to satisfy in terms of whether a given research question is a good question. And one of my own mentors in graduate school, Chima Ndumale, he would often ask me a question I now ask my students, which is, for this given question, what would change in policy based on what you found? Whether it's, a negative effect, a positive effect, a null effect, what would change? And if you can't answer that question, it still might be an interesting question, and maybe it might be worth doing, but it's not a question that is going to sort of meaningfully move the needle in public policy. And frankly, it's a pretty high bar. Ensuring that there is a clear policy target for a given question is often really hard to satisfy. And I think it's one of the hardest things to do in coming up with good questions. So that's maybe my biggest piece of advice, which is that, ensuring, again, if you're in the business of doing applied policy research, ensuring that you have some sense of sort of what would change based on what you found, that there is some clear policy target for your work. I think that's by far the most important thing. And I have to be honest, I think that's something that can be very difficult to sort of teach in grad school. And that's a skill you sort of have to invest in on your own. And I think there are a few ways to do that. And maybe this is sort of digressing into things you want to get at later in the conversation. But one thing for me is it does highlight the importance of really having some on the ground experience, either in the industry that you want to study or in the sort of target for your research. And so if you're interested in health economics, that can mean having some sort of on the ground experience, in the healthcare delivery system, in the payer setting, in the pharmaceutical sector, in government. But understanding operationally how things work and how people consume information is really important. And, I think this is one way I benefited from being effectively pre-med for a long portion of my undergraduate career. I spent a lot of time, volunteering in emergency departments, and in other clinical settings. And I think that did a lot to help me understand, what it means to practice medicine, and how folks sort of respond to the different incentives they face in the clinical setting. I remember it had a big impression on me. So John Skinner is an immensely successful health economist at Dartmouth who's had a very impactful career. And there's a sort of apocryphal story about how he, early on in his career, took effectively the entire medical school curriculum. He's not a physician. He's trained as a PhD economist, but felt that if he wanted to study how clinicians respond to incentives and understand information and understand uncertainty, then it was important that he do his best to understand the environment in which they operate. And so I think getting that experience is really important. Another example I'll give of a colleague who I think has used that experience to be very impactful is a colleague at Yale, Jacob Wallace, who before going to graduate school spent a fair bit of time working in the New York Medicaid program. And so he fully understands the challenges that Medicaid programs face, the constraints they face, how they use research, how they think about using research to inform the work they're doing. And I think that's done a lot to inform, his career and made his work, particularly impactful. And so, I think to the extent that what makes for good research questions is sort of knowing what's important and knowing for what questions there's a clear policy target. I think one of the best ways to know what's important is to have, real world on the ground experience. And I think there are a variety of ways to get that. One is to pursue work in that field before your PhD. So, between undergrad and a PhD, for example, maybe if putting off the now sort of traditional pre-doc by a year or two to do that work. It's also something you can get exposure in, during undergrad. In health economics, I think this is one way, I collaborate at times with folks who are both MDs and PhDs. I think that sort of clinical experience brings a lot of richness to the work. And I think it's important that we, PhD trained folks also sort of invest in understanding the environment in which the folks we're studying operate. I'll just say the other way to sort of get that is by reading widely. And it's not just reading, the peer-reviewed literature in health economics or health policy, but, reading the news, understanding what are the major policy issues, reading the trade press, the industry press. I think that's really important. What are, the CEOs of the biggest healthcare companies, what are they focused on? What are state policymakers focused on? Doing your best to understand what they care about, because in the end, those are the folks who are in a position to act on your work. And, I think doing research where there's a clear client, there's a clear target, there's someone who can make a decision using that information, that is sort of critical to doing impactful applied policy research.
So a follow-up question on that, as your research is mainly involved in public policy engagement, can you tell your experience with policymakers? How far inputs from academic research helps in the shaping up of public policy?
Yeah, so I guess first thing is, let me just reemphasize this idea that I think engaging with policymakers, if you want to do applied policy research, is really important. And I think it's important for three sort of key reasons. One, I think just sort of echoes the points I was just making, which is that it helps to ensure that your questions matter. Like actively engaging with policymakers, what their concerns are, what sort of timely issues they're facing, and you can do research that's responsive to that, where you're helping to sort of engage in this policy feedback process. I think another benefit of engaging with policymakers, and I should be clear, when I say policymakers, I'm in part talking about folks who work in government who help to run programs. I'm also meaning folks in industry who are affected by policy or other settings. I think another benefit and sort of key motivation for engaging with them is really to understand technical details and mechanisms that may not be obvious from the data itself. And this is, I think, key for engaging in sort of hypothesis generation around mechanisms. I think there's lots of benefit to sort of mixed methods research where you can sort of estimate a causal effect and maybe find heterogeneity in that effect. And it's only in really talking to people that you understand why that heterogeneity might exist. And that maybe is difficult to tease out in the data, but actually engaging with people brings some additional sort of impact to the work and makes it sort of more actionable in that way. It also can help you understand sort of technical details about what you're seeing in the data. Just to give you one example from some current work. So within the Medicaid program here in the US, we have something called emergency Medicaid, which is a very sort of restricted form of the benefit that's specifically for emergency situations, and it's primarily meant for people who have undocumented immigration status, who don't otherwise have access to healthcare coverage, but who would qualify for Medicaid on the basis of their income, and it covers access to emergency services. And so we're trying to study this benefit really for the first time in these new national Medicaid data I mentioned. And we're seeing all sorts of weird things in the data that are just difficult to understand. And so we found it really helpful to sort of talk with the folks who run these programs in states to understand if what we're seeing in the data is a quality issue or is real, and it sort of help us interpret what we're seeing. So I think talking to policymakers helps you understand what's important, helps ensure there's a sort of policy target or client for your work, helps you understand technical details about the data, and then also I think in many cases it can provide access to data that you wouldn't get otherwise. And so these partnerships can sort of facilitate access to data that can allow you to again sort of answer really, really important questions. I'll give you sort of one other example here where I recently finished up a long project trying to understand how the Medicaid program in the US affects racial and ethnic disparities in participation in clinical trials. And so in the US and globally, we know that clinical trials, the folks who participate in trials, are not representative of the populations who would stand to benefit. And that has all sorts of important downstream consequences. And so we did this project trying to understand in the US to what extent is sort of Medicaid policy an underlying factor. And so to do this project, we needed individual level data on who was enrolled in what types of trials, in what states, and their characteristics, including their race and ethnicity. And there really is not a good nationally representative public data set that gets at this information. And so in this case, the folks we partnered with to do the research are an industry. It's a company called Metadata that provides the sort of back-end IT infrastructure for a lot of the clinical trials that are conducted both in the US and globally. And so they have really rich de-identified individual level data on clinical trial characteristics. And so that work wouldn't have been possible without that sort of industry partnership. And so I think there's huge importance to engaging with policymakers, and I sort of use lowercase p policymakers to mean folks in government in the US, whether at the federal or state level or local level, but also folks in industry who are can provide lots of really rich data, but also sort of additional sort of context on what you're seeing in the data. And so I think that's really, really important.
So as you spoke about data sets, shall I ask you that what are the most important factors and the Now, what we see, especially in growing up economists, the collection of data is very
Hey, Gopal, I'm so sorry. You broke up quite a bit there. Would you mind asking the question again?
Yeah, you said about data collection. Yeah. So nowadays, data collection is a very problematic in growing economic countries where we have to pay money to get the data. So can you give suggestions to our early career researchers how to take the data for
Yeah,
their
so
research?
I have to tell you that's a challenge here in the US as well. So, in health economics, two of the most powerful data sets for conducting research, Medicare and Medicaid claims data, are really expensive and difficult to access. And so, challenges in particular exist for students who want to access those data. Thankfully here in the US, up until now, the government basically subsidizes the cost of accessing the data for students, and so it's much cheaper, but still, decent cost to it. And so we've been working really hard to think about, ways that we can improve access and lower some of those costs. Um, one I think way students in the U.S. often can get access to those data a bit easier is by benefiting from sort of broader resources at their university. And so one thing people often don't think about when they're choosing PhD programs is what data does my university have on hand? But thinking about what resources may exist already that you can leverage in your work, I think is really important. And at this point in the U.S., but globally, I think one of the key assets that universities have invested in is both infrastructure to support high intensity data-driven research, but also actually purchasing a lot of that data itself and making that available, at least within the confines of the university as a public good to sort of lower the barriers to entry for students. So I do think universities sort of leveraging their economies of scale to improve access to data is one, I think, key strategy and one thing students should avail themselves of. I think there's also an important role, frankly, for professional societies like IHEA to play here. In the U.S., I know of a couple of different professional societies that effectively have grant programs specifically for students designed to make it easier for students to get access to certain types of data. It would be great to see, I think, maybe similar programs be formed globally to support the sort of global community in health economics. But I agree. I think one of the biggest sort of barriers to entry for many students who want to do this type of work is getting access to data. And I think we as a community need to think more about programs and policies we can put in place to improve access. One thing we've done here with research on the Medicaid program, again, where most of my work focuses, is we've created something called the Medicaid Data Learning Network, which effectively is a consortium of researchers across the US who are using these new generation Medicaid data to conduct research. And we created this consortium in part to support students and early career researchers to sort of lower the barriers to entry and make it easier for them to start working with the data by providing advice and code and other tools that would make it sort of easier for them to get started so they don't have to reinvent the wheel. It would be great to see the creation of sort of analogous organizations internationally, again, designed to facilitate access to different types of data sets.
Yeah. I hope that in the future, the data would be available to everybody. So coming to the final stages of the interview, as an academician, what are your advice to healthcare researchers? And also, I would like to ask you, what is the future for health economics as an academic discipline?
Yeah, so I think in terms of advice, I already mentioned the big one, which I think it's really important to get on the ground experience either in the industry you want to study or in the industry or setting that will be the consumer of your research. So that I think you can sort of better understand operationally what constraints folks operate under, as well as how they use information to inform their work. And so I think that's really important and sort of a critical first step to being sure that the work you're doing has a clear policy audience of some sort, has some clear sort of client who can act on it. I think that's piece of advice number one, and that helps you be able to sort of answer the question of whether a given research question is important, whether you can sort of rightfully say that what will change based on what you find for a given question. And I think that sort of surpassing that bar of knowing that is key to making sure the questions you're asking are really going to be impactful. I guess a second piece of advice I have, and this is also something that I think is difficult to learn during grad school, and so I think often can be easier to get elsewhere. And this relates back to, I think, my early interests in journalism. Writing well is, I think, arguably, the most critical skill to doing impactful work as a health economist. You can be the best econometrician in the world, but if you can't clearly motivate the question you're asking and discuss the findings in ways that are clear for potential end users of that information, then ultimately, I think your work can have, very limited impact. And so I think investing in experiences that really teach you how to write well is really important. I think, a lot of the other technical skills you need to be an effective economist, you get in grad school. Like you learn a lot of theory, you learn a lot of econometrics, you learn, you improve your coding skills, maybe some of your project management skills too. But learning how to write well, I think, can often be hard to get in grad school, in part because while we do a fair amount of writing, learning to write well requires doing a lot of writing. And, I think what was really critical for me in learning to write well was this experience in journalism where, in working in college for this student newspaper, I'd be writing, 2 or 3 articles a week. And it was like a brutal editing process where I write a first draft and then, an editor who was more experienced than me would sit at the computer in front of me and edit it, with me sitting there, and they would just destroy it. They would destroy what I had written. But I would learn a ton. Like it was brutal to sit through, but I would learn a ton. And I'd be doing that, 2 to 3 days a week for, a good portion of the year for a few years. And that sort of, repetition, I think, is critical to learning to write well. And so seeking out, I think sort of analogous opportunities where you can do a lot of writing and get a lot of feedback on that writing is really important. And that could be through, additional coursework in graduate school, but I think often can mean seeking out, writing opportunities outside of sort of the formal curriculum, and opportunities where you're not just writing a lot, but getting a lot of, really, really good feedback, and ongoing feedback. I think that's really important. I guess my last piece of advice, is maybe a bit cliche and common, but doing research is really hard, and doing work that is designed to meaningfully inform public policy is really hard. And I think key to doing impactful work is being willing to fail. There's this famous like Thomas Edison quote that's something like, I've not failed, I've just found 10,000 ways that don't work. And so being willing to fail and try something else, I think is really important, particularly if you want to answer important questions where like there may not be, a super obvious clean identification strategy, and you need to sort of be creative to think about getting at it the best way you can. Going back to this project I mentioned, looking at how Medicaid affects equity in clinical trial participation, the data set we ended up using to finally write that paper that involved a partnership with industry, that was like the fourth or fifth data set we tried to use to answer that question over, I don't know, 3 or more years. Each of the data sets we tried to obtain and use before, either the quality wasn't sufficient or the sample size was too small, so we were underpowered. We ended up, having to try for multiple times to find something that would allow us to credibly, answer what we saw as a very important question. And so I think people are often given the advice that, you should like fail and fail fast. And I think there's some value to that. But I think there's also a lot of value to being a bit resilient, and particularly for important questions that, may not have sort of the cleanest study design, being creative and entrepreneurial and thinking about, what's out there that might help me answer this question better, and firing off an email to see if maybe something might come of it. There's often sort of no harm in asking. The worst that happens is someone says, no, we're not going to give you those data. So I think being willing to sort of fail, and as part of that, being sort of really entrepreneurial is also really, really important.
So thank you for a beautiful advice to the early career researchers. So the last and final question before ending the interview: what are your future projects in research?
Yeah, so I think two big things on the horizon. One right now, so I mentioned that in the Medicaid program, we saw during the pandemic enrollment increased to over 93 million people. And that was in part because of the fact that the US Congress passed a law during the pandemic that basically, highly incentivized states not to kick folks off of Medicaid when their income changes. So eligibility for Medicaid is in part based on income. And in general, when people lose a job or get a job or their income changes, they can come on and off Medicaid over time. So during the pandemic, that all sort of stopped, in part of the view that like during a pandemic, people should have access to consistent access to healthcare coverage. So enrollment increased a lot. And then with the pandemic effectively ending, states had to begin, resuming redeterminations of Medicaid eligibility. And so in the US, this is referred to as the Medicaid unwinding, the unwinding of those congressional provisions that initially led to that big increase in enrollment. And so we're doing a big, actually survey-based project in partnership with New York State, where we are surveying a large sample of people subject to redetermination of Medicaid eligibility, so who are in Medicaid and could be sort of losing it as part of this process, to understand sort of what happens to them. But we're also interested in a lot of other sort of secondary economic questions, a big one being, how salient is Medicaid coverage? And so in this project, we're going to marry survey data on sort of what people say their coverage looks like with administrative data on what their coverage actually is, to understand, to what extent they're aligned or misaligned for certain populations, and should we be doing more to sort of inform people about the benefits that they have access to improve the return on the investment we get from investing in public programs like Medicaid. So that's one big program, or one big project that I'm focused on right now. Another is, in the US, a lot of hospitals that serve low-income populations. So we often refer to them colloquially as safety net hospitals. So these hospitals are often at risk financially of closure, and when they close or propose to close, there's often a lot of community outcry, and policymakers are often sort of given the sort of question of whether they should intervene, whether they should somehow support the hospital and financially and stop it from closing. And so we want to do some work to understand sort of heterogeneity and the effects of safety net hospital closures, and what are the cases where policymakers should intervene to sort of mitigate perverse consequences, and when do we think intervention maybe less warranted. So anyway, those are two things on the horizon in the near term that I'm excited about, and one I'll just highlight that is in collaboration with policymakers, where we've benefited from chatting with them about the design of the study. We're benefiting from data they're giving to us to help us answer the questions well, and there's a clear end user of the work that we'll be doing, where they're really in a position to change how folks enroll and experience Medicaid based on what we find. And so I think another great example of how engagement with policymakers is just really, I think, critical for doing impactful work.
So first of all, let me wish you all the best for your two main projects and all the future endeavors. So thank you, William. Thank Professor William Schpero for joining us in this series to give advices to the early career researchers. And hopefully, we would see you at the AHIA Congress, Bali, in July this year.
Thanks so much for having me. This was a lot of fun. And yeah, if I can be helpful to anyone listening, please don't hesitate to reach out.
Yeah. So that was Professor William Schpero. I hope that all of you have a nice day, and till we meet again for our next interview series. Bye from me. So I hope the interview was good.
That was wonderful. I hope I was helpful, and I hope that the internet connection was okay. I guess you'll check the recording, but
yes,
if you need to record any part of it, shoot me an email. We can find another time.
Okay. And have a great day today.
Thanks so much. You too. Have a good one.
Okay. Thank you.
Bye-bye.
Thank you. Bye. See you.